we've got a couple of things coming up in May. It's a busy month for most of us. On May 12th, the Peace and Resolution Conference is happening. You know, I don't even know where it's happening.
It's at the Greenville Convention Center.
Greenville Convention Center, and Tyler Rex will be speaking actually on May 12th. So register for that. Grief Fest, May 13th through 15th. Grief Fest has named the Burleson Foundation as the sole recipient of the admissions proceeds. So if you go to Grief Fest and buy a ticket, the proceeds are going to come to the Burleson Foundation, and the more money that the Burleson Foundation raises, the more money that we can distribute back out to the community. So we would love your support. Plus, it's a lot of fun and there's great food. Bingo Bash is, sorry, let me back up a little bit. Para-triathlon is on May 15th, 8:30 a.m. to 2 p.m. at Newberry College, and there's a registration link on the Greenville CAN Facebook page. Next is our annual fundraiser, Burleson Foundation annual fundraiser, the Bingo Bash at the Carolina Farmhouse on May 22nd. It is free. Come and play bingo. There'll be a silent auction. We've got some great silent auction items and also some fun bingo prizes if you happen to win. We'll be presenting our spring grant recipients at the Bingo Bash. We'll also be presenting our first time Barbara Stone Community Leadership Award at.
Do you have to register for the Bingo Bash, or can everyone just show up?
You can just show up. Yep, you don't need to register. We'll have a food truck and a snow cone truck, and just come on out and play bingo. Yep. And a couple of other things. Next month's Lunch and Learn is Upstate Warrior Solution, and we'll be back to the second Tuesday of the month. And are there any other updates from organizations that are here today that might be relevant for people? No? Okay. Well, it is my pleasure to introduce David Burleson. He is the Regional Director for Business Development at Springbrook Behavioral Health, and he's going to tell us a little bit about Springbrook. Thanks so much. Have a good lunch.
Thank you. Can everyone hear me? Great. Well, I appreciate everybody coming out today. I'm going to talk a little bit about Springbrook today. I'm going to focus primarily on our child and adolescent services that evolve around our autism programs. Springbrook's got a little bit of a different history. We didn't start out in autism, but that's pretty much what we're known for at this point. So we'll kind of start. This is our mission statement. I always feel like it's good to have our mission statement kind of posted. But the mission of Springbrook Autism Behavioral Health is to provide the highest quality of care, exceptional services in the eyes of our patients, customers, and employees. To achieve this, Springbrook Autism program provides structure, effective support for children with autism and their families. So now that we've got that out of the way, I'm not going to do any more reading because I do not have that memorized. So I'm going to go a little bit through Springbrook's history because we've got a little bit of a different history. Again, we didn't start with autism. We kind of stumbled into it. So kind of want to walk through a little bit. We are actually celebrating our 40th year anniversary this year. So we have been here in the upstate for 40 years. We haven't always been named Springbrook, but we kind of went through a little different iterations over time. But 1979, we actually filed our articles of incorporation. Didn't actually open for our beds at that point, but we actually started seeing patients in 1982. So that was back when we had the World's Fair in Knoxville. I was about 4 years old at that time, and we built the Sun's Fair, which is still there. So I was from Tennessee originally, and that's what I remember from 1982. 1987, we actually began treating patients, child and adolescent patients, on a residential perspective. So the types of folks we were seeing at the time, these were kids with mood, conduct disorders, oppositional defiance, and we were doing this on a residential basis, meaning these kids actually came and lived with us for a time, meaning between 3 months, 6 months, a year. They would come in. Some of these kids had years and years of trauma. We would work on them. At the time, it was CBT, or what we call cognitive behavioral therapy. But then we kind of built in the trauma piece, as that started to kind of evolve over the years. Originally when we were open 40 years ago, we actually were open to treat PTSD in veterans. That's kind of how we started, our owner and founder actually is a disabled veteran himself. So naturally, we've worked with the VA very closely over the years. So when we started the child adolescent side, we really wanted to kind of focus on the trauma piece as well. So moving into the 2000s, nothing really changed. We were still kind of doing our inpatient for adults and our residential. 2010, actually, we started seeing patients on the autism spectrum for the first time. Actually, that was my first day and Dr. Fisher's first day. He and I actually started on the first day, and I got the body slammed. It was great. We were going through MAN training, which is actually de-escalation, and it's when you try to essentially restrain patients non-violently. But I actually kind of got under him and he fell over. I'll say I body slammed him, but actually he kind of tripped. But he and I started working on the same day. And part of my original charge was to help start his outpatient practice. We started it started pretty slowly. I guess the idea of a psychiatrist that specialized in treating kids with autism was relatively new because there wasn't, a psychiatrist in the upstate that specialized in treating autism. So, the first 2 or 3 months started slowly. My CEO was at the time was a little bit concerned. I said, just, wait, just give it a couple more months. By 6 months, we had an 8-month waiting list. So, once it kind of got out there that, we were seeing kids, we started getting flooded with referrals. Another thing that helped as well is not only see a child and adolescent psychiatrist, but we also take Medicaid, which you don't really see a lot of folks doing that these days. In 2016, we had a new CEO that came aboard, and we decided that we were going to move down the route on a residential side of opening a program for autism residentially. We did that, started taking our first patients. Initially, we did a horrible job with it. Our patients did not de-escalate the way that we wanted them to, and it really kind of made sense. If you take a kid with autism who a lot of times what's driving those behaviors is anxiety, and you take a kid who has heightened anxiety and you put them next to a kid with oppositional defiance or mood cognitive disorder with octopus arms, the next thing you know, their anxiety is going to go to the roof. So we said, okay, let's pause this thing, let's figure out how we should structure this thing and really build these programs from the ground up. So, we wanted to make sure that we kind of segregated that population to make sure that we could focus specifically and solely on what their needs are while minimizing the distractions around them. So we really started, we began building those programs from ground up, not realizing at the time how groundbreaking that was. Essentially what we did is we looked at, evidence-based practices and we'll get into this in a little bit, but essentially built what now is being recognized as a national leader in residential for kids with autism. So we're among the most robust programs in the country with what we're doing. So, and we've been recognized for that as well by TRICARE, also by Joint Commission, which accredits hospitals. So we've come a long way since the first patients that we saw residentially. In 2019, kind of speaking of breaking the eggs, we actually started and launched our adolescent autism acute inpatient and assessment program, which is a mouthful in its own. We call the Blueprint program. That's a lot easier to say. So we'll go into all of our programs right here in a minute, and I'll kind of explain that program. That's actually the only program like that in the country currently, but we do see that as we've had all of the commercial insurance companies agree to pay for that, we probably see that programs like those are going to start being adopted across the country. So I've just got some basic terms up here, that are going to be used in here. I know you never know the group you've got in front of you, so just wanted to find some of these. So ASD naturally is autism spectrum disorder. PRTF is psychiatric residential treatment facility. So if you hear that, essentially that's the long-term residential that we have, or if you see PRTF, that's what it means. ABA is applied behavioral analysis. This is a type of therapy that we use for kids with autism. BCBA is a board certified behavioral analyst. This is essentially like the top level person who does ABA therapy. There's low levels, RBT, whatnot, but we have some BCBA, so they're mentioned in there, and then naturally ADD, everybody knows, is attention deficit disorder. Well, I hope everybody in here knows that. So let's get into our programs. Springbrook Behavioral Health, our autism programs, we have 3 distinct types of programs. We have our child and adolescent autism PRTF, again, our residential programs. Our adolescent autism acute inpatient and assessment, or our blueprint program. And then our child and adolescent outpatient psychiatry. So those are the 3 main functions that we have in our hospital for kids with autism. So again, we have from the highest level of care, which is the residential piece, down to the inpatient acute, which is stabilization, but we also do assessments in that piece, all the way down to an outpatient side. So those are what we have there. You can see under the child and adolescent PRTF, we have 7 residential programs. Those vary between ages, those vary between IQ levels and also communication skills. We have folks at our hospital that are nonverbal. We have folks at our hospital that need help with their ADLs. We need, they need help, wiping. They need help pretty much doing everything. We have IQ levels that are below 70 in some cases that aren't very measurable, all the way up to folks that you may not know would have autism unless you sat with them for a couple of hours, but they have their behaviors kind of dictated them coming in there. I tell folks all the time, because I have parents, when they find out how robust our programs are, coming into our programs, having autism is not, the only criteria. The folks that come to us have severe behaviors. So, just because you might want to get ADA for your child or speech therapy, whatever we're providing, still it's the severe and acute behaviors or psychiatric issues associated with an autism spectrum disorder is what leads to, someone coming to Springbrook, specifically, in our inpatient and residential programs. So keep that in mind as we're going through these. These are not just our typical kids with autism. These are kids that have had very severe, aggression, very severe behavioral issues and or psychiatric issues. So most of these folks have been placed, unfortunately, several times. As an example, for our kids in our PRTF, our average kid comes in on 7 psychotropic medications. 7 psychotropic medications. For multiple reasons. One, those kids, and again, a requisite to come in has been that they've actually been placed or hospitalized 3 times in a psychiatric unit within a 12-month period. These are kids that have the most severe behaviors. So what we see is that there's a lack of knowledge from a psychiatry perspective, and what you see with kids with a neurotypical issue versus what you see with kids on the spectrum is a lot of times medications we expect to have a certain result of a kid that may be neurotypical. Sometimes you don't get the same result for a kid on the spectrum, and sometimes you actually get the opposite result. So as you don't have many psychiatrists that are actually specifically trained in autism or developmental pediatricians, they just start throwing stuff against the wall. And actually, a lot of times what we see is when we start titrating kids off the medication, their behaviors start to increase just when we start taking them off their medications before we can even get into what's going on with them. Same thing can be said for the adolescent acute. Naturally, our children on the outpatient psychiatry, they're actually seeing psychiatrists, and or nurse practitioners that have been trained for autism. So, if we do have that problem when they come to us, we definitely don't have that problem with us. They typically are on the most appropriate meds at that point, at least from our professional opinion, we believe. So we get into the child and adolescent autism PRTF first. Our residential programs provide a strong, reliable source of stability and security for those in our care. We help create structures that minimize stimulation, promote learning, and decrease destructive behavior. Essentially what that means is we try to provide an environment for these folks to thrive. We're taking kids that come from all different types of backgrounds, that have triggers that we don't know what they are. Some of these triggers, again, could be anxiety. Some of these triggers could Anxiety could be from visual stimulation, it could be from sounds, it could be from all different types of things. Typically what we see is about 75 to 80% of the severe behaviors that we're seeing that are just straight from autism. I'm not talking about the mental illness piece. We're not talking about psychosis, which typically sets in later in the teens. But when we're just looking at pure behaviors that are driven, you take the hormone piece out as well, they're going through puberty, but about 75 to 80% typically is driven from anxiety. That's where we're seeing a lot of these behaviors derived from. The other 25 to 20% of these behaviors typically come from frustration. It can be from communication, not being able to communicate like they would like, or not having people understand how to communicate with our folks. Or it could be, issues with, tactile issues, being able to pick up a fork and eat like they would like. So, we employ a lot of different types of therapy at our hospital to help with these things. But we also try to, again, reduce stimulation. This is actually a picture of one of our classrooms at the hospital. These kids, again, come and live with us. So they also have class while they're with us. Those chairs look kind of neat because those are weighted chairs. If you think you can pick one of those things up and throw one, good luck to you. Those things are super heavy. But believe it or not, they're very comfortable. But we have class time. If you see those three nice little things on the wall, those are actually our schedules. Our kiddos love to know what they're doing and when. If we have math and it ends at 9 o'clock or 8:59 and reading starts at 9 o'clock, and we go over and math is at 9:01, our kids will let us know we're not supposed to be doing that anymore. It's time for reading. So we have visualization of our schedule posted at all times, so they know what they're doing. It helps with transition, but as you notice, it looks kind of boring, doesn't it? Not a lot of colors on the walls. We don't have cool little paintings and things like that. We don't have puzzle pieces painted everywhere. And that's actually a very specific thing that we've done. We're trying to reduce visual stimulation because a lot of times that can actually bring folks up and elevate their behaviors. We don't want someone to be bothered by that. Those lights that you see as well are not just our typical lights. Those are daylights. They don't hum, they don't glow. Some of our kids, when they walk in, we had one kid that we saw we just could not reduce his anxiety, couldn't figure out what's going on. And what it was is he could actually hear, we had a light socket that was humming, and we ended up figuring out, it was a frequency we couldn't hear. Somehow he was able to pick up, got an electrician to come in there, fix it. He was fine at that. That's relatively amazing, but something that there's no way I can pick up. But everything that we have in there, as boring as that looks, was extremely purposeful. We did years of research, as far as making our place look that boring. So that's kind of the way that we go with that at Springbrook. We spend a lot of time to look very unimpressive. So, what can families expect, when they come in? What can our folks expect? Well, we have family group therapy sessions, between weekly, monthly. It just depends on how often we feel like they need it, how long they've been with us as well. A lot of times we find that, as soon as the kids come with us, we just start to see this eruption of behaviors. Sometimes we find that as soon as the kids come with us, we actually see that we're not seeing the behaviors they have. Sometimes their parents can be triggers. It doesn't mean their parents have done anything wrong. It just means that sometimes what their parents are doing, they don't understand. It's kind of setting the kids off. So we try to figure out what those things are. We have those family therapy sessions to kind of help their parents figure out, okay, this is what may be escalating your kid. These are things that can kind of help bring them down. We also have monthly treatment team meetings. This is led by our psychiatrist, but includes all types of experts, speech therapists, occupational therapists, their individual therapists, their case managers that they have, if they have, state agency involvement, all that kind of good stuff, before they come in. Typically treatment teams have probably 8 to 12 people on there, as well as, who's, the consumer themselves. We have individualized behavior plans that are actually written by PhD BCBA. That's for every kid that comes in. So we don't have a one-size-fits-all program for our kids. Every program or every kid actually has a program designed specifically for them. And naturally, those things are modified. Then after the behavior plan is written, we go over it with our psychiatrist, our speech and occupational therapist as well. So we're all on the same page. So as far as age, genders, this is a little bit about us. We take kids 5 to 21. Now, when I say 21, they have to come to us before they're 19, but they can stay until they're 21. So kids, you know, they have to be there before their 19th birthday, but they can't stay until age 21. We do take male and females. Our IQs can vary down below 70 up to genius IQ, you know, 150, 160. You know, we take folks at all levels, verbal, nonverbal, bathroom trained, non-bathroom trained. You know, we've had several kids that have, you know, 14, 15 years old that have been wearing diapers when they came into us, and we had potty training within 2 weeks. It's not always, you know, but, you know, those are some success stories that we've had. So we'll move on to our Autism Acute Inpatient and Assessment, our Blueprint program, because I'm going to get tired of saying Autism Acute Inpatient and Assessment program. It's a mouthful. So our Blueprint program, and there's a reason it's called Blueprint. So this is an intensive program. It's a 28-day program. So I'll talk a little bit about inpatient and residential housing district. So as I mentioned earlier, a lot of our kids have been hospitalized 3, 4, 5, 6 times within a 12-month period before they come to us. This is kind of like that in a certain way. When kids are hospitalized in an ER and they go to a psychiatric hospital, which typically is only MUSC, because usually having autism is an automatic disqualifier at pretty much every other psychiatric hospital in the state. What they do is it's crisis stabilization. It's not treatment. It's not none of that. And I tell people that all the time on our adult side. You know, when you go into an inpatient setting, you're not there to treat your problems. You're there to be stabilized. So when you leave, your treatment can work. You know, you're to a level where you're not in danger to yourself or others. Well, what we decided to do was actually kind of do a mixture of things, because what we started to see is a lot of these kids that were going in and out of ERs. One of the reasons why they're going in and out of ERs is because they may not have necessarily had a clinical diagnosis. So if you don't have a clinical diagnosis with BDSM, you don't qualify for services. So you're just going to bounce in and out, in and out, in and out. Now, I don't know what BDSM's time is right now to do testing. I know pre-COVID, it would range between 12 and 24 months. After COVID, I have no clue what it is right now. So we naturally saw a gap in there, and we're like, well, you know, if we're going to be doing stabilization, you know, for kids on the autism spectrum, we're probably going to see some of these kids have severe behaviors in another 2 weeks or a month and a half. And we're not doing anything for these kids. I mean, essentially, we're just taking them out of the community and, you know, putting them in a stressful environment. You know, anytime you're pulled out of home and put in a strange place, it's stressful. So we decided that, well, let's do a stabilization program, but let's, you know, kind of add to it to where maybe we can get them qualified for services when they leave, so they're not bouncing in and out. Maybe they can go ahead and start qualifying and get ABA, you know, therapy, speech therapy. You know, we can get them connected, because we're going to do naturally a discharge plan as well. So we decided to add a discharge component to it and an assessment component. Now, this is designed, you know, to reach adolescents on the spectrum with an IQ of 70 or higher, and there's a very specific reason for that. So they have to be able to respond to verbal prompts, naturally, because again, you know, there is a goal that we're trying to set here, and you know, but they have to also be exhibiting again these behaviors that are going to interfere in their daily life. So we use the same evidence-based practices that we're doing, you know, on the residential program. But the reason why, you know, they need to be able to have an IQ over 70, be able to respond to verbal prompts, is because of the assessment piece. We can stabilize anybody, but again, we want a program where we can, you know, have kids hopefully not come back to us, that we can kind of wrap in services. And we also see that, you know, if we had enough of these, that we will reduce the need for the residential component that we have. It won't eliminate it, because some kids just have behaviors that are severe. But some of the kids we see, if we could have wrapped them with services that they should have been getting before, they never would have got to the level where they would have needed a residential level of care. So we can do psychological testing when these kids come in. We can go through CARS, RAT, ADOS, whatever we need to do to get them qualified for services through BDSM, go ahead and get them ready on, when they leave, that they can have pretty much all of that clinical diagnosis ready. Dr. Fisher is hands down the best psychiatrist you're going to see. He can walk into a room and tell you within 5 minutes the kid's on the spectrum. His diagnosis means nothing to BDSM because it's not a clinical diagnosis, it's a medical diagnosis. So they require clinical diagnosis, so now we're doing clinical diagnosis on this inpatient assessment program. So our goal is actually to reduce these kids going in and out of psychiatric hospitals. We don't want that. We want these kids to be able to qualify for services. So we're not seeing these kids, 5, 6, 7, 8 times. We want these kids to be able to be wrapped, with services, be able to get them and, be able to be as, like we are, just be able to, stay in the community and not have this be a part of their lives. We've all got our different things. I got a therapy for this. You might get a therapy for that. You might get a therapy for this. So, we just want folks' life to be as normal as possible. And if you're constantly having to go in and out of the hospital because people don't know how to get you stable and keep you stable, then it's going to be a vicious cycle that you go through. So again, this program is crisis stabilization. We do assessments and testing. We also do family education. We give discharge instructions. This is what you need. So we'll do assessments for not only the psychological piece, but speech therapy, occupational therapy, applied behavioral analysis. This is what we recommend that you get. We'll make, we'll give recommendations on who to call. If they did not have the psychological testing before, if they weren't qualified for services for DPSM, we'll refer that. We can refer them to Family Connection, the Autism Society, whoever, to kind of get them connected at the IAPs. So we kind of go through that whole process, but we also give them, as you can see, the blueprint guide. This is why it's called the blueprint. This is a personalized guide. It has their assessments in it. It has a behavior plan for them. It has a reference guide in there as well. It's about that big, but they're all personal for these folks. And some of them don't stay 28 days. They go through, they have their worksheets as well that are in these blueprints. And, if they don't complete them and ever need to come back, then they can always, continue where their progress was. But that's why it's called the Blueprint Program, because we actually give them something tangible when they leave that they can continue to work on when they're gone, or they can go back and reference while they're out. So the ages that we look at for this is a little bit different. We're looking at 10 to 21. Now, I need to specify as well, the 10-year-olds need to be a little bit bigger. We'll have to look at our milieu. If we've got a bunch of 16, 17-year-olds that are 6 foot tall and 200 pounds, we're probably not going to take a 10-year-old this big. So we do look at, the folks that we have, especially if they're extremely aggressive. Sexual aggression is something that we're not going to take either. So if somebody has a history of that, unfortunately, that's not going to be a patient we accept, because we don't want to be putting our folks in jeopardy when they're coming in to a hospital. They're there to get care and not there to, have anything potentially done to them. But we also take male and female, again, IQ above 70, and they do need to be able to respond to verbal prompts, where clinical therapy will work, and we can do the assessment component on them as well. Now, these next couple of slides I'm going to go through is our specialized programming. Now, this is going to be for both the programs that I just mentioned, our inpatient and our residential. So again, we do applied behavioral analysis. Naturally, we have the psychiatry component, we have the management piece. This is with Dr. Fisher. We also have 2 nurse practitioners that we've trained. They trained for 2 years under Dr. Fisher. And then we also just brought in a child mental health psychiatrist. I brought him in. I guess he's been with us for about 9 months now, and he's been training under Dr. Fisher as well. So he's going to be handling the inpatient piece. Dr. Fisher will be doing the residential component, and then the the outpatient side as well. So we have 5 prescribers in-house right now because we're training another nurse practitioner as well that are learning, that are either specialized or learning a specialization right now in psychiatry, which is great because I hope they end up leaving us and going out in the community. I know that sounds weird, but I could call Dr. Fisher 5 times over and we still wouldn't have enough prescribers in the Greenville area for psychiatry. So they're great employees, but we can always train more. We just need a lot more than what we've got out there. And if we end up having to be a training ground, so be it. That's great. We can always hire some new folks and train them as well. But we do therapy groups. We work on a reward system. We don't punish folks for bad behavior. You know, we don't believe that really works, but what we do have is a reward system. So when people, you know, would stay with us or are showing progress, we reward them for that. We work on sensory integration. I've got a picture of one of our sensory rooms right here in a minute on another slide. I can show that to you guys. Again, as I mentioned earlier, we have a visual schedule, behavioral plans, we do speech and occupational therapy, recreation therapy. We do extracurricular activities, pretty cool stuff actually. You know, they've done the baseball, was Miracle League they've done this here locally. We have an indoor gym, so they've actually competed with some of the schools that come there. We've actually done some basketball with them, kickball. We have an indoor swimming pool, so they do. We've actually had somebody come and do aquatics therapy as well. Had some some equine therapy out there as well, where we've had some horses come out. They love the horses. But we do a lot of different kind of stuff like that. We've actually taken field trips with some of the folks who we've got, you know, that we feel like their behaviors are to the point where, you know, we feel like they're pretty stable. We can take some of these folks on field trips and, you know, that we don't feel like there are locus issues or anything. We also have a high staff client ratio. The state requires us to have a 6-to-1 staffing ratio. The lowest ratio we have is 3-to-1, and we work from a 3-to-1 to a 1-to-1 ratio. So our ratios at the highest point that we have are half of what's required. So you know we have more staff, you know, per patient than any other hospital in this state, and we far surpass any other state as far as their guidelines, and we feel like that's something that's more appropriate within this population than we see typically in your traditional residential settings, psychiatric residential settings. As far as our education, we work with the Einstein Academy, you know, which is an accredited school here locally. We go through them. So we got, you know, we teach in the classroom. I will say that everything that has its basis in applied behavioral analysis. So even our education components, our teachers are all trained in ABA and actually all become RBTs, registered behavioral technicians. So even our teachers understand applied behavioral analysis. We actually work that into the education component. You see, we have all day, year-round school. So that is very intentional. When we first started doing this, we had the 3 months off, the 2 weeks off for Christmas. We have a week off for Christmas now. Spring break, all that kind of good stuff. Greenville County Schools years ago, before we did autism, actually used supplies for the teachers. But then when we moved to the autism piece, you know, we started hiring our own. But what we saw is when we had kids that had an entire day with nothing to do, wow, that was fun. You know, they actually, a lot of our kids like the structure of being at school, believe it or not. And we'd see those behaviors go off the chain sometimes. So, you know, we've moved to a full year all-day school. Our curriculum is individual, it is self-paced. You know, but all of our teachers, you know, are certified teachers, you know, at least bachelor's level and multiple or master's level special ed teachers. So, you know, here again, it's kind of a summary of some of what we just went over. There's a couple other things in there, this for evidence-based practices. You know, as far as the metronome, biofeedback, visual cueing, I didn't really get into any of that. Working on social skills, you know, social stories, those are really big with some of our kids as well. You know, I don't know if anybody here knows Susan Lively. She was with the Autism Society for years, has 2 kids. Well, you know, she was talking about, you know, when she would take her kids to Outback, you know, they'd have a sign, you know, blokes, you know, for the boys, you know, and instead of just male or female, you know, you know, have to use the bathroom and go there and didn't know what a globe was, and you just stand there, you know, and you have a little boomerang and no idea. So, you know, we kind of have to tell social stories with our folks sometimes, you know, to kind of get them to relate, because, you know, where they may have very great talents at certain things, some of these social things, you know, that you and I may take for granted, some of them don't necessarily, you know, draw a line from A to B. They might go from A to F to D and then go back to B. So, you know, we try to have those social stories in there to kind of teach them to how to relate a little bit differently. You know, because unfortunately, you know, we need to be able to learn how to relate with some of our folks, you know, a little bit better as well. So, and then we have forms of payment, because this is a question I always get. So we do accept Medicaid. These are for our inpatient and residentials for multiple states. Now I say multiple states because it varies. We're actually not contracted for either service right now in South Carolina for Medicaid, but we do single case agreements with them. So in some states, like every state in the Southeast, except for South Carolina, we actually have a contract. So it's a lot easier. In South Carolina, we actually have to have a lot of hoops we have to walk through. We're hoping to clear that up. Actually, I'm going to be meeting with the state director of DHHS next Thursday. My CEO and I are going down there to kind of discuss that. I actually do all the contracts and rate negotiations as well, so that's why I'm kind of a part of it. So we're going down there next Thursday, and we're going to have a discussion, you know, to try to see if we can go ahead and just do a pure contract, not have to have 78 people involved when somebody needs this, and it takes 6 weeks. It'd be a lot nicer just to get somebody in, you know, in a little bit more appropriate amount of time. But at least that has changed over the last year and a half, because before then it'd been a long time since we've had anybody in South Carolina on Medicaid, I guess I should say. We used to have a contract with them, and then they changed a lot of things in 2017, and it wasn't a good thing. But we're, you know, like I said, we're remaining optimistic that, you know, next week we're going to kind of move down that process. But I think currently we do business and we have kids from 27 states that come to us right now. We have 3 from Alaska, just to kind of show you how far kids are coming to us right now. TRICARE, we're in all the national TRICARE networks. We're actually nationally benchmarked by TRICARE as well as their gold standard of what an autism hospital should look like. Commercial insurance. Actually, we're contracted with every major commercial insurance company that I can think of for residential and for our inpatient at this point. I got the last one contracted with about 3 weeks ago, so I probably should have updated this. And then we do single case agreements with other state agencies as well. If we don't have Medicaid contracts, we'll, you know, sometimes contract with some of those as well. So that is our inpatient residential. So these are some of the activities that our folks do at Springbrook when they're with us. Again, we have therapy dogs. We actually train therapy dogs at our hospital. That little booger down there at the bottom is our oldest therapy dog, Jesse. Actually, before we trained them, Jesse was given to our psychiatrist, Dr. Fisher. If anybody knows how expensive therapy dogs are, they're about $70,000 for some of these folks. So they actually were so impressed what we were doing. The company was they gave Jesse to Dr. Fisher. He's lived with them ever since. So he was our first. Now we actually have some trainers on house. So you've got little dogs walking to the house all the time. That is our indoor pool. So that's actually ours. And then that is also our indoor gymnasium. If you see those little panels on the wall, those are actually fabric that reduces the noise while they're in there, so it's not super loud when you're in there. Yeah, we actually just had the pool resurfaced and painted and all that kind of good stuff. They actually look a lot better in person. That kind of looks dark, but when I first started working there, they look a lot better than how they used to. These are our directors for our child adolescent services. We have Dr. Matt Fisher. Again, he and I started on the same day. So this, if y'all heard of the famous Dr. Fisher, this is him. He's recognized as a community expert treating autism spectrum disorders. And then we have Brandon Clark. He's a PhD and a BCBA. So he's been with us now, I guess, about 3 years. And he's done a very good job. He's kind of taken over a little bit for Dr. Killian. Dr. Killian's still with us. If anybody knows him, Bill Killian, he's still with us, but he does more writing behavioral plans at this point, as he's kind of stepping down, facing down a little bit. But I've got some of our other folks listed on here as well, just to kind of show you some of the team of folks we're working with. We have Dr. Jeffrey Craddock as another psychiatrist. Believe it or not, Dr. Fisher actually did his training for psychiatry when he was a medical student under Dr. Craddock. That's where Dr. Fisher decided he wanted to be a psychiatrist, and now Dr. Fisher is training Dr. Craddock on autism. So it's funny how those little circles work. Then we have Dr. Bill Killian as well, as far as another BCBA. We've actually already hired 2 more BCBAs, but I haven't put them on there yet because they're not finishing orientation. From a nursing perspective, we have Amy Stewart as our PRTF nurse manager. She's also a nurse practitioner. We've also have Sarah Hall. I don't have up there. She's another nurse practitioner that we have. She kind of floats between outpatient, inpatient, 2 speech therapists, an occupational therapist that's a CODA. We've also hired an OT that's above a CODA, and then Jake Edgar is our director of education. And again, these are more of our leadership roles. We have tons more people that are working below them as well. So you can see we have a pretty robust staff that's helping us. So lastly, we'll get to our 3rd program, which is outpatient psychiatry. This is med management, essentially anxiety, but for kids on the spectrum. And these can be for anxiety, ADD, psychosis, and many other complex issues as well. You know, Dr. Fisher at this point, from a volume perspective, doesn't take many patients anymore. Essentially, the only folks that we take are specifically from prison and developmental pediatrics. And if they're coming from those, they're typically extremely complex cases that their developmental pediatricians don't necessarily feel comfortable with the autism piece, and they send to us at this point. Those are the only ones who he agrees to take. But again, we do have 2 nurse practitioners that trained under him for 2 years that are still accepting patients. Now, our ages, I have 5 to 18. That's true, and it's not true. That's as far as who we accept. However, we do not age out patients. So Dr. Fisher and I have been working together for 13 years now. So as you can see, we actually have some patients in their 30s. I know we don't accept patients initially in their 30s, but we don't age out patients because we also know that some of these folks would have nowhere to go. So we continue their treatment indefinitely, essentially. As far as payment as well, we get questions on that. Commercial insurance, South Carolina Medicaid, NCOs, self-pay, whatever. So, you know, payment's not typically an option with that. And actually, to be honest, we lose about $400,000 a year on having this psychiatry practice. My CEO was willing to close it a few times. I've just told him no. I think that's kind of our obligation to this community. And we have all these families that would have nowhere to go otherwise. And if we write it off as our part to the community, then I feel like that's what we need to do. So we will continue in the foreseeable future as long as my CEO doesn't step in and disagree with me. But he did kind of agree, you know, that, that makes sense, and that, these families wouldn't have anywhere to go. When he came in, I don't think he actually understood, where we're at in this community and how few folks out there are willing to treat these folks. And now that I think he's seen it, not only has he embraced, our role, but he's forged ahead. And that's why we went from one program to Dot Howard, where we've got, 7 residential, the inpatient and assessment, as well as, agreed to continue the outpatient piece. So my CEO that I've got now has been with us for about 8 years, and he's a phenomenal man. So, what we've been able to do has been remarkable at Springbrook, and a lot of it's been under his leadership, but it's also been because we've been lucky enough to find these experts that have been out there. And, like I said, the best thing for us would be if our professionals, a lot of our folks would leave us and then go out in the community and be able to start spreading their wings and training folks too. Because, like I say all the time, we could clone Dr. Fisher about 5 and there still wouldn't be enough of them. He's a fantastic guy, but I mean, he's my age, and I got a 1-year-old at the house, and I'll tell you, I don't have the energy I had 10 years ago. So if anybody has, needs to know how to refer, this is our direct line to referrals and admissions and our websites. So I guess I'll open it up now to questions. Did I go long enough? Did I go too long? No. Any questions as far as our programs, anything like that? It was so thorough that, like, even with a white glove, you guys could find a speck of dust. Oh yeah, we got one.
I manage a program for adults, that many of ours are on the spectrum.
Sure.
And several of our families are struggling to find someone that will do outpatient therapy services for their adults.
Oh, I'm sure.
Recommendations.
Nope. Well, let me change that. There's a couple of therapists that I know that will see folks. You know, again, it kind of depends on the therapist, depends on the payment source. You know, we had actually the first therapist I recruited from the board with us. Actually brought her to the upstate. I say I brought her up. I was lucky enough to recruit her up to the upstate. Jill Jones. She's in a practice called Burleson. Actually, just a few blocks away from here. Now, Jill used to do child adolescents, and then she switched over to where she started seeing mainly adults. This was 5-6 years ago. I'm not sure where she's at as far as that practice now, if she's still accepting patients. You know, so since she left, actually one of our former therapists as well, that did have an autism specialization, decided to specialize in autism when we started transitioning from that trauma-focused CBT, and actually trained under Jill. So she went out as well. I think she may actually be in the same practice. So I will contact them, Bay Laurel, specifically ask for Jill Jones, and they may be able to do therapy sessions. But you know, I tell folks all the time, when you hit 18, you know, you go from 60% of the services that you would hope you get down to maybe 5%. When you get 21, it's almost zero. I mean, and it's awful. You know, we had our autism conference last week, and you know, one of our goal sponsors, you know, was looking at starting something specifically for you know, the elder adolescents that are transitioning into adulthood. What they're looking at is fantastic, but my question is, how do you pay for it? Now, I think it's going to be a mix between SSI and other things. If they take off, naturally, I'm recommending this meeting. They need to be here to talk about it, but I think they've got a, what's it called? Something White House is what they've got right now. I'm trying to think of the name of it, but it's yes, but they're looking at something much larger. So they've got kind of like seems like a clubhouse thing, but what they're looking at, if they can do, will be fantastic for the community. But you know, once you hit 21, it's really tough. Now, you know, we've kind of made a change recently because of our specialization, where we will accept patients on the autism spectrum who are adults into our stabilization that are coming from hospitals and ERs. But again, that's because nobody else will. But it's not, again, I tell people all the time, inpatient is not treatment. It is stabilization. The problem we see with that is that, you know, are they going to be going somewhere where they're going to be getting treatment? Because that's not anything that we're set up to do at this point. But there's not a lot out there right now. So I recommend Jill Jones, contact, you know, them in Simpsonville, you know, and like I said, if they're able to take off, you know, with this project we're looking at, it'll be great. They'll probably fill up pretty quick, but there's just not a lot for adults out there right now. You know, SOS has a pretty good plan for what they're doing down in Myrtle Beach, but that's 5.5 hours away. Any other questions? Yes, ma'am.
A little off the topic. You guys still have the services for the adults there?
Yes, ma'am. Yeah.
You still have the inpatient residential?
We do. Well, no, not residential. It's inpatient, which is short term, like, you know, typically 5 to 14 days. It depends on, you know, the program. We have, so, and we've actually, those programs are called our Havenwood programs. So we have inpatient site. So that's more of, those can be split between, you know, your chronic, you know, disorders such as schizophrenia, psycho, things like that. And then we also have depression, you know, more acute things, like acute depression. Then we have detox and dual diagnosis, which that's typically only 3 to 5 days. You know, the detox piece is, and those are alcohol and benzos primarily. We can detox off other things like opioids or things like that, as long as the psych is the primary diagnosis. And then we have a geriatric program, which is typically about 10 to 14 days. But yeah, so you know, the longest somebody's with us on average is usually only 2 weeks. It's usually 5 days to 2 weeks. So yeah, but they're on the other side of the campus, yes, ma'am. But that's what I was saying. We'll take some adult patients into those programs, but they have to be very specific. Again, they have to have an IQ of over 70. They can't be too aggressive coming into those, because again, if we're going to be doing, you know, individual therapy, group therapy, they have to be able to, you know, have communication, be able to, you know, have things like that. Yes, ma'am.
I have to tell you, I'm an alumni of Springbrook.
Okay.
And really appreciate you guys and your service. You all personally well.
Oh, great. Well, thank you so much.
Thank you so much.
Yeah, like I said, we've had an up and down history, so it sounds like we had a, you know, it's a good time when you were there. Yeah, we went through and we changed a lot of our programs. We've been there. I know, as an example, when I started, we only had an inpatient unit, and we opened the detox and dual diagnosis, and then we go to the geriatric. So from even the way it looks, I mean, we pretty much gutted it out completely and rebuilt everything, you know, from the inside out. So just the changes I've seen in the years I've been there have just been phenomenal. Actually, I think Dr. Fisher and I, the only 2 people who've been there longer than Dr. Fisher and myself is one lady in housekeeping, and then our executive admin, Lisa. I think are the only 2 people that are tenured there longer than us. So yeah, it's been kind of amazing to see what we've had go on there. So I appreciate that. Any other questions? Well, thank you.
So yeah, thank you so much for David for coming out and presenting for us. Again, my name is Chris Sparrow. Laura was here earlier. And we just do want to give out a few quick reminders. So the Down Syndrome Association of the Upstate is having their Mouths on Fire competition, hot chicken wing eating contest tomorrow night in Greer. So if you want to go to something fun and support a local agency, then definitely do that. They still have tickets for sale, am I right? Okay, yeah. So you can go online to their website and get tickets.
You don't have to eat the hot dog.
Okay, so you don't have to eat the hot dog.
You have a regular chicken. Yeah.
Okay, all right. Perfect. All right, and then yeah, again, we have the Greek Fest and the Bingo Bash coming up. I want to clarify something real fast with the Para Triathlon. That's just a clinic. It's not an actual full competition. Don't worry, you don't have to recommend that people are gonna, you know, do however many insane miles that is. But it's just a clinic. It's down in Newberry College on Sunday, May 15th. And I think that covers it. Anybody else have anything they want to share with the group? Okay, so you're welcome to stay around and network. We encourage you to, and meet and talk with others. But thank you very much for being here today. Appreciate it.